Good afternoon, everyone. For those who don't know me, I'm Asif. I'm one of the second-year PulmCrit fellows. I'm going to be talking on the pulmonary manifestations of HIV today. Special thanks to Dr. Higab, who was my faculty mentor for this presentation. I have no disclosures. My general outline is going to be on for the talk is going to be I'm going to start off with the epidemiology and then talk about the general approach to a patient presenting to the clinic with HIV and pulmonary symptoms. And then the most of my focus is going to be on the non-infectious pulmonary manifestations of HIV. And with these, I'm going to be focusing mainly on malignancies, obstructive lung disease, ILD, and PH. I understand we've had a few talks at least on the general manifestations of like the infectious complications in immunosuppressed patients. And that's why I kind of wanted to just focus on the non-infectious manifestations this time. Now, beginning with the epidemiology, the HIV Outpatient Study is a landmark epidemiological study for HIV patients. This was studied in HIV clinics since between 1993 and 2017. The primary focus of the HOP study was on health outcomes and mortality in almost 11,000 patients. And what we saw was, what we see is that in general, the mortality from HIV has significantly decreased from 121 per 1,000 patient years to 16 between 94 and 2017. But not just, we know that the mortality has reduced, but also the HOP study showed us that there have been significant shifts in morbidity in patients with HIV. In the early days, we had more opportunistic infections, and more recently, we're seeing an increase in the incidence of the non-infectious manifestations, mainly your obstructive lung disease and malignancies. This is a graph from the HOP study, which kind of is reflecting what I just mentioned in terms of mortality. We see with the red line, we're seeing that the mortality has decreased since the advent of antiretroviral therapy, and patients are living longer. So the median age of death has increased. Now, how about the epidemiology of pulmonary manifestations? There has been a change in the spectrum of the pulmonary manifestations in HIV-2 since the advent of antiretroviral therapy. We are seeing more of the non-infectious pulmonary manifestations now. But despite this, in areas where there is no access to care, or in patients who are not on antiretroviral therapy or chemoprophylaxis, infectious diseases still continue to predominate. Whereas in the developed world, we are seeing lesser opportunistic infections. So there is a growing recognition of the non-infectious manifestations. This was HOP study basically was published last year in the Clinical Infectious Disease Journal, but over the last 20 years or so, they have come up with interim analyses. And this was from one of the interim analyses from the HOP study from back in 2006. Focusing on these triangles, the triangles basically represent pulmonary mortality in HIV patients, and you see that as with the overall decrease in mortality, the mortality from pulmonary disease is also decreased in HIV patients. Now, this bar chart is basically a representation of specific pulmonary disorders as a percentage of total hospitalizations in HIV. And we're seeing that the black bar in this bar chart represents all pulmonary conditions, and we see that over over time, we're seeing a decrease in all pulmonary conditions. And this is mainly reflective of decrease in opportunistic infections, because the second bar there actually represents PCP infections. So as PCP infections are decreasing and other opportunistic infections are decreasing, the overall hospitalizations from pulmonary conditions is also decreasing. Now, this bar graph actually is a representation of the other organ system. So total hospitalizations as depending upon a particular organ system. So the black bar graph is pulmonary reasons for hospitalization, and that has been decreasing. The second bar in the bar chart is actually a representation of the cardiovascular hospitalization, cardiovascular risks for hospitalizations, and we are seeing that more and more HIV patients are being admitted with cardiovascular reasons as opposed to pulmonary conditions. So following epidemiology, I'd like to go over the general approach to a patient who presents to the pulmonary clinic with HIV and pulmonary symptoms. And I'd like to, in terms of the overall approach, I'd like to focus on first of all, the clinical assessment, the importance of Cd4 counts and imaging, and then go on to talk about our physiology, sputum analyses, and other invasive and non-invasive testing. Now, in terms of the history, most of our history is focused on trying to tease out the infectious manifestations, because the non-infectious manifestations usually are very non-specific. But in terms of infectious manifestations, a history of a patient being in a healthcare facility or prisons or shelters increase the chance of a patient having tuberculosis. And also, residence or travel to an endemic area would give you an increased chance of a patient having an endemic fungal infection. But not just this, in HIV patients, it's a little different too, because either residence or travel in the past becomes important, because now if the patient had an endemic fungal infection in the past that they were asymptomatic from, and then they develop HIV later in their life, you have new immunosuppression, and with that, you can have reactivation of these fungal infections. The other important point to remember is with antiretroviral therapy, we see immune reconstitution. With immune reconstitution, you're seeing the recrudescence of dormant illnesses that were there before. A classic example being post introduction of antiretroviral therapy, a patient presenting with fever, lymphoid granulomatosis, gets our basically bells ringing for latent TB infection in these patients. And lastly, in terms of history, it's always important to know what medications a patient is on, specifically with other immunosuppressant medications, or some of these immunosuppressant medications can have risk of pulmonary toxicity. Now, once we have a page, we've kind of tried to tease out the history part of the encounter. Going on to exam, along with examining a routine cardiopulmonary examination, I think focus also needs to be on a good dermatological exam and also lymphoid granulopathy. So significant lymphoid granulopathy would point towards a diagnosis of either TB or lymphomas, whereas a good dermatological exam can give us some important clues. The first image is actually the mucocutaneous manifestation that I've seen in histo. The second are molluscum lesions that I've seen in crypto, and the third one here is a verrucous lesion that's actually seen in blasto. So a good dermatological exam also helps tease out the diagnosis that we're seeing. Moving on to Cd4 counts. So once you have a history and exam, we're looking at the lab. Cd4 counts are especially important. This is a little bit of an older study back in '97 in the Blue Journal. This was what is called as a pulmonary complications of HIV study. They looked at the incidence of different pulmonary manifestations over a 5-year period, and they stratified this based on their entry-level Cd4 count. I know it's a little difficult to see this, but the squares, up in the first part of the graph actually represent bronchitis in general. And if you were to kind of turn your attention to the entry level Cd4 count less than 200, and the last part of it, we see those stars and the crosses. The crosses actually represent opportunistic infections in general. And we see that, in terms of the overall highlights, what we recognize from the study was acute bronchitis still remains the most common respiratory infection. Pneumonia and TB are typically seen in early HIV before you see the opportunistic infections and neoplasms, but pneumonia and TB also occur more frequently as immunity declines. In fact, over time, what was seen in the study was the incidence of bacterial infections increased 40% each year. So that's quite a significant increase over time with something like bacterial pneumonias. And as we all know, PCP, disseminated fungal disease, and CMV is usually seen in lower Cd4 counts. So once we have kind of talked about the history and the Cd4 counts, imaging becomes important. I know this is a little bit of a busier slide, but in terms of imaging, what is really important is the timing and the pattern of imaging that we see. So in terms of timing, acute versus chronic becomes important. So someone presenting with an acute consolidation or an acute nodular infiltrate is more representative of a bacterial infection as opposed to more of a chronic manifestation of these radiological findings could be something like an atypical infection or fungal infections or even malignancies. Another important study that I'd like to kind of focus on is how about these patients who, we get consulted on the inpatient service. They don't really have a lot of pulmonary symptoms, but they have HIV and they have abnormal radiographic findings. This was a study that was out of Bellevue Hospital and was supported by NIH, basically looking at patients with HIV with radiographic abnormalities without respiratory symptoms. And what was seen was, first of all, they looked at, what were the radiographic abnormalities, and then eventually, what was the final diagnosis in these patients. And we saw that almost 57% of these of patients actually had nodular pathophysiology, followed by lymphoid granulomatosis in 17% patients. But what was kind of interesting was eventually not all of them, you had a final diagnosis, but in the patients who we had final diagnosis, and that is 44 patients of the total, we ended up in the final analyses. We saw that of these, almost half patients had an infection, and almost 20% patient actually had a malignancy. So, typically we see a patient HIV, just radiographic abnormalities and no symptoms, but then when they had more workup, we see that almost 20% patients actually had a malignancy. So being cognizant that not all our HIV patients have pulmonary symptoms is an important thing to remember. How about CAT scans, when compared to chest X-rays? This was, again, a little bit of an older study back in 1999. They compared routine chest X-rays with CAT scans and across different, pulmonary manifestations of HIV, Kaposi's, PCP. And overall, we do see that the sensitivity of picking up diseases would be higher with the utilization of a CAT scan. And in patients with a positive CT, 17% actually had normal chest X-ray findings. So stopping at a chest X-ray may not be sufficient in a lot of our patients, and they may end up requiring a CAT scan. So after talking about like the general clinical assessment, Cd4 counts and imaging, I'd like to move towards physiology and sputum analysis. Now, in terms of physiology, a lot of our patients do end up getting PFTs, but I'd like to talk about a couple studies that almost kind of, I think are important because they give us almost a historic perspective of how we started looking at PFTs in patients with HIV. So this was back in 92. What they did here was with HIV patients who came in, they put them on a stationary bike and had them exercise for 10 minutes. And if they desaturated with exercise to below 90%, that was considered a desaturation with exercise. And what they saw when comparing desaturation with exercise to just having hypoxia at room air or infiltrates on a chest X-ray, exercise-induced desaturation was actually the best independent predictor of PCP. I know it's almost impossible to have these, to keep a stationary bike and then, every patient with HIV who comes to the clinic, putting them on a bike for 10 minutes may not be feasible, but maybe we can extrapolate the results from the study to use it in, say, a 6-minute walk test. So even though the study, may not have a direct implication, I think there are good indirect implications of the study. Another important physiology parameter that is especially in someone like in patients with PCP is diffusion capacity. This study is also a little old. Back in 99, they used an algorithmic approach. What they did was, patients who had clinical signs and symptoms of PCP, they got a chest X-ray, and the patients who had a negative chest X-ray, they had diffusion capacities performed. And patients who had low diffusion, that is less than 75%, those patients underwent further diagnostic evaluation with sputum induction bronchoscopy. And overall, the results, the authors concluded that decrease in diffusion may be present before the development of chest X-ray abnormalities in these patients. So even with a normal chest X-ray, having a diffusion abnormality would necessitate further workup with sputum induction and BAL, things like that. Talking of sputum analysis, now a lot of times, when we have, especially in TB, in suspicion for tuberculosis in our patients who are either inpatient or outpatient, do we need to send everyone for a BAL? What is the utility of using sputum induction? Now, this was published in the Blue Journal 2000. It was a single center study from Brazil, compared sputum induction versus BAL. And what they found was no significant differences in the yield of sputum induction or BAL, both in smears and cultures. And the agreement between sputum induction and BAL was actually pretty similar. So for AFB smears, the agreement between sputum induction and BAL was 98%, whereas for cultures, it was 86%. So sputum induction can potentially give us good enough information and even sufficient information to diagnose TB. And this is another important study that I wanted to bring up, and that is the utility of using Mycobacteria TB PCR. Now, I know that our ID department sometimes is able to substitute 2 negative Mycobacteria TB PCRs for 3 AFB smears. This was a study, again, published in the Blue Journal in 2000, that actually compared the sensitivity specificity of using PCRs versus the gold standard, which is AFB smear and culture. And what we saw was, even though the specificity of a Mycobacteria TB PCR is high, the sensitivity is extremely variable. So someone who has a positive Mycobacteria TB PCR, you can you can safely make a diagnosis of TB, whereas with a negative study, you cannot exclude the diagnosis. Now, after thinking about the general approach of clinical assessment, the counts, imaging, and physiology and sputum analysis, I'd like to talk about, just touch base upon other non-invasive and invasive testing. Now, in terms of other non-invasive testing that's at our disposal, we have different fungal antigen testing. So urine histoantigens, things like that, galactomannan. You can perform fungitiles, especially for invasive aspergillosis and PCP. For PCP, we have PCP PCR and LDH levels that can be performed. You can perform viral panel PCRs. And PPD testing, right? So, but with PPD testing, it's always important to remember that PPD testing depends upon your Cd4 count. So negative test in a patient with Cd4 count less than 300 you cannot rule out either a latent or an active TB infection. Other invasive testing, again, this happens a lot in our patients, especially the ones that we see on our consult service. We go through most of this workup, but eventually a lot of these patients require invasive testing, and that is with a bronchoscopy. And with bronchs, the main utility is to rule out infections. Transbronchial biopsies at times can give us some diagnosis, especially of non-infectious disease like Kaposi's or even interstitial lung disease. And then EBUS TBNA becomes very important because, as I'm going to be discussing the importance of malignancy in HIV, we can diagnose lymphomas and also lung cancer staging with EBUS TBNAs. At times when even this is not sufficient, we may need to perform surgical lung biopsy with either VATS or an open lung biopsy to get more information. So we talked about the general epidemiology and an overall approach to a patient with HIV who presents with pulmonary symptoms. Now I'd like to move on to my primary topic, which is my focus on the non-infectious manifestations. Now, starting with malignancy, HIV-related malignancy can be classified into the AIDS-defining cancers and non-AIDS-defining cancers. Now, the AIDS-defining cancers are your Kaposi's, primary CNS lymphoma, non-Hodgkin's, and cervical cancer. This graph, or this this table, is comparing the standard incidence ratios of patients with both AIDS-defining and non-AIDS-defining cancers when comparing the pre-HAART era to the early antiretroviral therapy era. And we see a significant decrease in the incidence ratios of AIDS-defining cancers post-HAART era. However, the non-AIDS defining cancer, especially lung cancer, the incidence has probably remained the same, or in certain studies, we've actually seen an increase in incidence of the non-AIDS defining cancers post-HAART. And this is another a good graphical representation of the point that I just mentioned. The darker shade is representative of the AIDS defining cancers, and we see that the incidence is reducing, whereas the lighter shades are the non-AIDS defining cancers, which have actually been increasing. Now, and how about the what I talked about in terms of the AIDS defining cancers increasing with the AIDS defining cancers decreasing with antiretroviral therapy. This was published quite recently in 2018 in the Annals. What they did here was, amongst the HIV patients, they separated the HIV patients into essentially three categories, and that was the HIV positive patients who were on no ART. The second was HIV positive patients who were in early antiretroviral therapy, and the ones who had long-term suppression. What we see here in terms of the AIDS-defining cancers, we see that the patients who are not suppressed, they had, of the 474 patients who were not suppressed, the 40 ended up having an AIDS-defining cancer. So pretty significant increase in incidence ratios amongst the patients who were not on antiretroviral therapy. And this also was replicated in specifically in Kaposi's, wherein we see that the incidence ratio for patients who were not on antiretroviral therapy is significantly higher. Now, how does HIV cause malignancy, or how is it implicated as an etiology in the etiology of malignancy? It's multifactorial. Immunosuppression does play an important role. If you kind of look at it's kind of difficult to look at this, but on the chart wherein the numbers are mentioned 1, 2, and 3, they kind of are representative of the direct effects of HIV, specifically causing immunosuppression, reduction in the anti-tumor response, and increase in the AIDS-defining cancers. Along with that, since the patients are living longer, we're seeing more and more non-AIDS defining cancers just because of longevity. The other associated factors are co-infections with other oncogenic viruses and environmental factors. So patients have an increased, patients who have HIV have increased, they have increased levels of smoking and alcohol, which in turn are implicated in other, non-AIDS defining cancers. In terms of, so that was like the general, I guess, the pathophysiology of how HIV causes malignancy. But now we will be discussing some specific malignancies that are seen in HIV patients, beginning with Kaposi's. As we all know, Kaposi's is a low-grade vascular tumor caused by HHV-8 infection, the human herpes virus 8 infection, which is also called the Kaposi's sarcoma herpes virus infection. It's the most common HIV-associated malignancy, and it is an AIDS-defining cancer. And we see that, as I had discussed earlier, there has been a marked decline in the incidence of Kaposi's after the advent of antiretroviral therapy, and this is likely due to immune reconstitution. Now, in terms of how HHV-8 is implicated in Kaposi's, we see here that the HHV-8 infections, HHV-8 infects endothelial cells primarily. And along with the when the HHV-8 infects endothelial cells, in addition to the HIV-infected lymphocytes, they together, initiate a complex cytokine response. Eventually, what happens is you have a polyclonal proliferative response. So you have these endothelial cells, they undergo polyclonal proliferation and end up with what is called as the spindle-like network, essentially. And more spindle-like network surrounds the blood vessels, and the blood vessels kind of shrink down. We will see in further slides, the characteristic pathology that we see with Kaposi's are these spindles and slit-like spaces, which are basically the compressed blood vessels that we see. And this is a complex interplay between HHV-infected endothelial cells and HIV-infected lymphocytes. Eventually, after the polyclonal response, these cells undergo transformation into a monoclonal, almost a monoclonal proliferation that eventually results in a malignancy. So, and that is how it is implicated. But what is also important to know is the pathogenesis of Kaposi's is not restricted just to the oncogenicity of HHV. Along with the oncogenicity of HHV, we need a cytokine-induced response and some sort of immunosuppression. So there are a complex interplay of all these three things together eventually results in Kaposi's. And in the further slides, I'm going to focus on how all these three things basically act together. In terms of the variants of Kaposi's, we know of the classic, the endemic, and HIV-associated Kaposi's are the more common ones. The uncommon ones are the Kaposi's that's actually associated with immune reconstitution. And particular focus also needs to be on the Kaposi's that is a part of the inflammatory cytokine syndrome response. So patients who actually have this variant of Kaposi's, the variant which has inflammatory cytokine response, they present very similar to someone with HLH or macrophage activation syndrome, or typically like how our COVID patients could present with. And that is, just an overwhelming cytokine response. But more important than that is, in terms of the etiology of Kaposi's, the most important factor that's associated with is low Cd4 counts. This was published, from the Cascade collaboration, looking at Kaposi's in HIV. And what they found was the most important factor was a Cd4 count less than 200 had a relative risk of almost 12 times, in basically increased risk of developing Kaposi's. So a low Cd4 count is very important. And then going back to this slide, when I was kind of mentioning that along with HHV, you need some kind of an immunosuppression to proceed towards Kaposi's. A very important study here was looking at just steroids and the risk of developing Kaposi's, specifically Kaposi's iris. These curves, the first curve is basically, in the first curve, you have the bold line represents patients who were on steroids, and the dotted line is the ones who were not on steroids. And the first curve is looking at time to iris, and the second curve is looking at time to death. And what we concluded with this was that steroids actually can result in induction of Kaposi's. So, and even exacerbation of pre-existing Kaposi's. And in patients who have HIV and were started on antiretroviral therapy, steroid therapy in conjunction could potentially cause Kaposi's iris. And a lot of times, Kaposi's lesions can regress when you stop steroids. So having that immunosuppression is an important aspect. In addition, we've also seen that certain opportunistic infections can also induce Kaposi's, and we don't know what the mechanism of this is. We suspect that some pro-inflammatory cytokines can play a role. So that was kind of like talking about the etiopathogenesis of Kaposi's, and now moving on to clinical manifestations. Now, most often pulmonary Kaposi's, 80 or 90%, is actually associated with mucocutaneous manifestations. The first picture is, basically we see this plaques and macules in a patient along with periorbital and perinasal edema that we're seeing. The second is looking at almost a Christmas tree-like distribution of classic Kaposi's lesions. The third, are these reddish tumors that are seen in the hard palate gum area. And the last one is this violaceous plaque that is seen in the glans penis. So mucocutaneous manifestations are the most common ones, are the most common presentation of Kaposi's, and more than 85 to 90% of our patients who have pulmonary Kaposi's actually have mucocutaneous manifestations. Pulmonary Kaposi's can happen by itself only in about 15% of the patients, and this is without mucocutaneous manifestations. And pulmonary Kaposi's can basically involve either just the lung parenchyma. It can involve endobronchial disease. You can have endobronchial disease from Kaposi's, pleural effusions, and just lymphadenopathy. These are the four big presentations. Parenchymal lung disease, the symptoms are usually non-specific, dyspnea, hypoxia. Endobronchial can be asymptomatic, or you can have evidence of upper airway obstruction, hemoptysis. Pleural effusions can occur in up to 2/3 of our patients, and sometimes they're large and difficult to manage. In terms of how they appear, and I think this is very important to note, that the appearance actually on imaging has a pathological correlation. So a typical appearance would be, 60% of our times, it's usually patchy reticular opacities, and about 25%, you have nodular opacities. When we're talking of the reticular opacities, they're usually linear, bilateral, peribronchovascular, basilar predominant, and they actually represent the tumor infiltrating the septa. The nodular opacities, again, it can be single, multiple, diffuse. Usually, these represent proliferation of the neoplastic cells within the lung parenchyma. Again, these are typical chest X-rays. The first one is nodular, basilar predominant. The second is more extensive nodular. The third one is basically looking at pleural effusion, and the last one is more of these reticular opacities. In terms of CAT scans, again, very similar presentation, but we are able to look at it better, obviously. The nodular pattern, because this is, remember, this is an angioproliferative response, you see centrilobular nodules, because it involves the blood vessels, essentially. And in addition, you can have reticular pattern, you can have pleural effusions. This is the typical CAT scan appearance, and here we see multiple nodules. What is important to note is these arrowheads, right? So the arrowheads basically are looking at a couple important things, and that is, the peribronchovascular distribution of the nodules, and this appears almost what is called as flame-shaped appearance. And the small arrow on the, almost in the right upper lobe area there, that is mainly looking at a centrilobular nodule surrounded by ground glass, which can typically give you the halo sign or what's called the Ethel sign. And this is again the flame-shaped lesions in the peribronchovascular distribution. Now, how about what's the role of bronchoscopy in parenchymal disease of Kaposi's? Usually to rule out infections, but also we can do an HHV viral load PCR on the BAL sample, and this has very high sensitivity and specificity, 100% sensitivity and 98% specificity. So that's something which we can use. Cytology is usually not used. We usually use it to rule out or to look at other infections that can have inclusions. And biopsy is usually needed to make a diagnosis. In biopsy, we typically see the spindle cells that are surrounding the blood vessels. So an airway exam is important in endobronchial disease, but otherwise bronch in a BAL is what is important. Now, biopsies, that is endobronchial and transbronchial biopsies, probably don't have a very good yield, and a lot of these patients, because they're vascular, can bleed. Biopsies, if obtained, the classic features would have what we talked about, and that is spindle cells, surrounding inflammation, and those spindle cells, and for the boards, this may be important, they stain for CD34 and CD31. The gold standard diagnosis is you take the biopsy, and on those biopsies, we run amplification, PCR amplification for HHV sequences, and then immunohistochemical staining can also give us enough information. So these two are typically the gold standard of diagnosis. And this is how it appears. In the first, we see this almost, we see the spindle cell proliferation, but more so the slit-like vessels around, and that is surrounding a whole nodule that we see. And the rest of them are the typical spindle-shaped proliferations that we see. Another important point I would like to make, and this is reflecting what we talked about earlier, and that is in A and C, we see the typical the typical reticular opacities and the pathological correlation of tumor within the septae. And in B and D, we are seeing the nodular opacities and the pathological correlation of having parenchymal lung disease. This is a couple more Kaposi's, CAT scan and pathology findings. In the first one, we're looking at pleural nodularity and how it appears on pathology. And sometimes Kaposi's, as seen in the slide and as seen in the images below, can appear with ground glass opacities and almost a crazy paving pattern, which is mainly representative of inflammation within the alveoli. Endobronchial Kaposi's appear as bright red, macular or papular violaceous lesions, typically branching points or even in the trachea. When we have a pleural effusion, we typically perform a thoracentesis, mostly for diagnostic reasons. There is not a direct diagnostic reason, but rather to exclude other infections. Therapeutic to relieve dyspnea in large pleural effusions, you can have a chylothorax in 20% cases. Pleural biopsy can sometimes be important, but it is always, but the most important thing with Kaposi's pleural disease is the lesions are actually on the visceral pleura, so closed pleural biopsy may not give us enough information. So overall, the presumptive diagnosis for Kaposi's is clinical when we have a typical epidemiology of, geographical location, MSM, in addition to your mucocutaneous lesions, immunodeficiency, Cd4 counts, radiological appearance, and after exclusion of everything else, we make the diagnosis. Tissue diagnosis is not always required, but if the information is insufficient to make a diagnosis, then an open lung biopsy is important. HHV, serology, and PCR in blood is not necessary, and it does not give us much information. In terms of treatment, this was a Cochrane systematic review looking at 6 randomized trials and 3 observational studies, 792 patients. Bottom line, the most important treatment for Kaposi's is to begin with antiretroviral therapy, especially in ones who are asymptomatic. If you're symptomatic or if you progress despite being on antiretroviral therapy, then concomitant chemotherapy is important. And usually concomitant chemotherapy is monotherapy. So there is no significant difference between either using doxorubicin, daunorubicin, or paclitaxel. And if you are already on steroids, then discontinuing steroids can result in regression of your Kaposi's disease. When you have airway involvement, although the upper airway involvement is rare, when you have lower airway involvement causing obstruction, atelectasis, then rigid bronchs, endoscopic laser resection, stent placement may need to be done, along with antiretroviral therapy and chemotherapy. Pleural effusions, when larger, are typically very difficult to manage. Repeated thoracentesis is one way to go, but if it occurs too quickly, then pleurexes may need to be placed. After Kaposi's, I'd like to touch upon non-Hodgkin's. Again, non-Hodgkin's is an AIDS-defining lung cancer. Usually, 85% are systemic non-Hodgkin's. 15% could be, the primary CNS lymphoma that we see. Non-Hodgkin's lymphoma in HIV is especially aggressive. Their B-cell origin, 60% are diffuse large B-cell and 40% are Burkitt lymphoma, with risk factors being low Cd4 counts and high viral loads. When it comes to pulmonary non-Hodgkin's, most of the time pulmonary involvement is a part of systemic lymphoma. Isolated pulmonary lymphomas are not very common, but they do happen. And when they do happen, again, the distribution can be very similar to Kaposi. So you can have parenchymal lung disease, you can have endobronchial involvement, you can have pleural effusions. The terminology primary effusion lymphoma is actually a separate entity. It is a kind of non-Hodgkin's lymphoma, which is actually a high-grade B-cell lymphoma, wherein you have not just pleural effusion, but also involvement of other effusions like ascites and things like that. In terms of clinical manifestations, very similar to HIV-associated non-Hodgkin's is similar to how other non-Hodgkin's presents with, except for a few differences. HIV-associated non-Hodgkin's is usually more advanced, more constitutional symptoms, more extranodal involvement. Pulmonary manifestations, typically, again, as I mentioned earlier, very non-specific symptoms, constitutional, tachypnea, cough. The involvement can be very similar to what we talked about in terms of Kaposi's. Parenchymal involvement can be either as an isolated mass or multiple nodules. In the first one, we're seeing significant lymphadenopathy and pleural effusions. That's another involvement. In B, we're seeing multiple nodules. In C, this is quite typical. This is typically described as lymphoid granulomatosis, when you have just bulky multiple nodules surrounding the peribronchovascular region. And D is pleural-based nodules. So how about, and this is something which we see, which we typically encounter quite a bit when we have this mediastinal lymphadenopathy, and we want to diagnose them for, non-Hodgkin's lymphoma with an EBUS-TBNA bronchoscopy. Overall, performing BALs is usually to rule out infections. Flow cytometry does add to this, but the yield with EBUS-TBNA and flow cytometry has not been very clear, and the specificity and sensitivity in HIV-associated non-Hodgkin's is not very well known. This was a good study in 2019, basically a systematic review meta-analysis of EBUS-TBNA in patients with lymphoma. of 14 studies were pulled together, and what we saw was the sensitivity was only 66%. The specificity was high, but again, you can have a lot of false negatives with EBUS TBNA in lymphoma. And that's why a lot of times when our EBUS TBNA, we don't, either our yield is not good, or if we have negative results, we do end up needing an excisional lymph node biopsy. When you have pleural involvement, you have thoracentesis may help in diagnosis. Fluid is usually exudative with lymphomas, lymphocyte predominant, and the yield of cytology can be as high as 75%. In terms of treatment, antiretroviral therapy is started, or if it's already ongoing, it is continued. So we have to have them on antiretroviral therapy. In addition, chemotherapy depends, the regimens depend upon whether this is diffuse large B-cell or Burkitt's. Moving on to HIV-associated lung cancer. The incidence of HIV-associated lung cancer has increased 2 to 4-fold. And this has remained constant. So, when we talk of the typical AIDS-defining cancers earlier, Kaposi's and non-Hodgkin's, post-heart, the incidence has decreased. But with lung cancer, that's not the case. Even with introduction of heart, the increase has remained relatively constant. We don't have any clear etiology. The oncogenic role of HIV is controversial. There is, an increased prevalence of cigarette smoking in patients with HIV, but this study that came out in 2007 actually, looked at the risk of lung cancer in HIV patients independent of their smoking status, and we saw that the risk of lung cancer remains even after correcting for their smoking status. And HIV associated with, in increased risk of lung cancer mortality. In terms of the characteristics, usually, this study kind of compared HIV-associated lung cancer to the lung cancer cohort patients who did not have HIV, and we saw that our HIV-associated lung cancer patients are usually younger. The stages and histology is pretty consistent. So adenocarcinoma and advanced stage or diagnosis remains consistent even with HIV patients. In terms of treatment, yes, we do treat HIV patients with lung cancer if their overall medical condition would permit us to. In terms of screening recommendations, there is no specific difference. The lung cancer screening recommendations continue to remain irrespective of the HIV status, and there's no specific special recommendation in HIV patients for lung cancer. But rest of the diagnosis and management remains the same, even in HIV patients. The last kind of cancer I want to touch base upon is Cascasance disease, which is also called angiofollicular lymph node hyperplasia. As the name suggests, this is a lymphoproliferative disorder associated with HHV. The typical kinds of Castlemans are usually unicentric and multicentric. Multicentric can be with or without HHV. And contrary to the AIDS-defining cancers, the incidence of HHV-associated Castlemans has actually increased since ART introduction. And we're not sure why this is. Maybe there is some role of immune dysregulation. The risk factors include low Cd4 counts, higher age, not being on ART therapy before, and non-Caucasian ethnicity, which is kind of interesting that patients who have not been on antiretroviral therapy actually have an increased risk of multicentric Castlemans. But epidemiologically speaking, even after the introduction of antiretroviral therapy, the incidence is increasing. Presentation of Castlemans is very similar to a lymphoma. So fever, constitutional symptoms, 5th and 6th decades of life. A biopsy is usually needed for diagnosis. On biopsy, we see, as the name suggests, follicular hyperplasia. So the onion skin layering is what is seen. The gold standard for diagnosis, similar to what we did with Kaposi's, is immunohistochemistry for HHV with what is called as the latency-associated nuclear antigen test. In Kaposi's, measuring the HHV-8 levels in blood was not useful. Here, some studies have suggested that using HHV-8 viral load in blood may be helpful in early course of the disease. The imaging is very similar to how either lymphomas or Kaposi's can present with, again, reticular, ground glass opacities, and pleural effusions, and CAT scans are, again, similar to that. And when it comes to management, management of Castlemans actually depends upon whether or not there is concurrent Kaposi's. If there is concurrent Kaposi's, then the treatment typically involves starting off with rituximab and doxorubicin together. So this is a combination therapy as opposed to Kaposi's, wherein it was usually monotherapy. Um, the this table is I guess a good summary of HHV associated pulmonary disease that we see in HIV patients. Overall, there are no significant, I mean, there's no specific recommendations for therapy, of Cascasance disease, but the treatments are usually threefold. First of all, we treat the HIV infection with antiretroviral therapy. We treat lymphoid proliferation with chemotherapy, and at times there is a role for treating HHV infection with antivirals. But this is for multicentric Cascasance, for Cascasance in particular, and that is controversial. So if you look at the second column there, the use of antiviral therapy is not recommended in Kaposi's, but is controversial in multicentric Cascasance. And the last column is again important in terms of chemotherapy. As I mentioned, Kaposi's is usually monotherapy, but with multicentric Cascasance, the treatment regimen would involve etoposide and plus or minus rituximab. There's also a role for anti-IL-6 therapy, either with cetuximab or toci in these patients. So we kind of talked about the epidemiology. Overall, we talked about the approach, and in terms of the non-infectious manifestations, we talked about malignancies, Kaposi's, non-Hodgkin's, Castleman's, and lung cancer in general. The last three things I'd like to touch base upon are obstructive lung disease, ILD, and PH. Talking about HIV and obstructive lung disease, this was published in the Blue Journal back in 2011, looking at the incidence ratios of different obstructive lung diseases, essentially, and other pulmonary diseases. The relationship between the epidemiological relationship, rather, between HIV and asthma is mixed. It's controversial. But we do see that HIV is associated with increased risk of COPD, especially, and we also see the incidence is usually at an earlier age. There's also a higher than expected rate of bronchiectasis in patients with HIV. The pathophysiology is again multifactorial. It involves chronic inflammation, recurrent respiratory infections, oxidative stress, protease anti-protease imbalance. So all of these things kind of play a role in the increased incidence of obstructive lung disease in HIV patients. In terms of pulmonary function testing, this was again published in the Blue Journal in 2010, looking at different pulmonary function testing abnormalities in HIV patients with obstructive lung disease. And what were the factors that kind of played a role? 167 patients, 64 had a diffusion impairment, and 21% actually had obstructive lung disease. And what we saw was, amongst the ones who had diffusion impairment, the factors that contributed were having any history of smoking and being on PCP prophylaxis. As opposed to the ones who had obstruction, the positive factors were actually, the more the smoking pack your history, the more you had risk of obstruction. IV drug abuse was also associated with increased obstruction, and antiretroviral therapy, patients who were on antiretroviral therapy actually had increased obstruction on PFDs. Clinical presentation is very similar to our non-HIV patients. And treatment, again, there is no specific, there are no specific treatment recommendations. There is some data on being cautious with use of inhaled corticosteroids in patients who are on protease inhibitors. Touching base upon ILD, the only big thing I'd like to kind of focus on ILD is the spectrum has kind of changed pre and post heart era. In pre-heart era, we had NSIP and LIP being the more common manifestations, but post, we're seeing more COP, HP, and sarcoid. Again, the presentations are for LIP, typically younger women, dyspnea. In this typical category of lung disorders that are associated with lymphocytic infiltration, which is called the diffuse infiltrative lymphocytic response patients, we do see signs and symptoms similar to Sjogren, so xerostomia, xerophthalmia. The imaging, again, depends upon the different manifestations. So we've talked, this has been discussed before. I'd like to focus on the last box, which is the LIP can present with green, but opacities and peribronchial cuffing. And in certain patients, you can have diffuse cystic lung disease from this. Pathology, again, depends upon the tinnitus. This is basically looking at NSIP and the interstitial infiltration of lymphocytes, macrophages, and plasma cells. LIP, again, this is your typical tree and bud nodularity, peribronchial cuffing, and the lymphocytic infiltration that we typically see. In terms of management, again, focusing on NSIP and LIP. With NSIP, it's usually self-limiting, but then there has been some benefit of using combination antiretroviral therapy that can help in some improvement of the lymphocytic alveolitis in these patients. With LIP, there may be some role of using steroids and antiretroviral therapy. And last topic that I want to touch upon is pH. pH, the incidence is approximately 1 in every 200 of our HIV-infected patients can have PAH. This is likely an underestimate, but we are seeing an increase in group 2 and 3 as patients are living longer. The pathophysiology, again, there is no effect of direct HIV infection on perivasculature, like the perivascular cells, but rather it is because of the viral protein kind of stimulating an endothelial response, resulting in HIV-PAH. Typically, routine screening in asymptomatic patients has not been performed, but the 2018 World Symposium recommendations are to screen them with an echo in patients who are symptomatic, or if they have more than one risk factor. So a lot of our patients with HIV, if they are females, then we need to get an echo in them, or if they have concurrent Hep C infection, known mutations, or if they're African American, these patients actually need to be screened with an echo, which is, I believe I remember reading this as a board question somewhere. In terms of diagnostic workup, again, this kind of just goes through the entire diagnostic workup of pH that we have seen before, but just to kind of focus on this last part, which says that, when you talk of the specific diagnostic tests that are performed to look at PAH diagnosis, HIV test is one of the important diagnoses that needs to be done. In terms of treatment, the benefit of antiretroviral therapy in treating HIV-PAH is not very clear. And there is also some concern that there may be specific antiretroviral therapies that can lead to progression of PAH, specifically protease inhibitors, ritonavir. And now this is, again, the same culprit we saw with COPD patients, because there was some interaction with inhaled corticosteroids and more risk of more corticosteroid-associated adverse effects with use of ritonavir. We see that ritonavir is, again, associated with increased development of PAH with an odds ratio of 1.75 in the study that I've quoted here. NNRTIs were not really associated. The other important thing is prognosis of HIV-PAH patients is poor. Patients with HIV having PAH is an independent predictor of death, and low Cd4 counts are associated with increased mortality. So overall take-home points, I know I kind of started late, so I apologize for ending late, we have a changing epidemiology of the pulmonary manifestations pre and post heart era, and need to be cognizant of that. A general approach would involve a good history and physical, assessing the amount of immune compromise of Cd4 counts, and also imaging thoracentesis when needed. And last but not the least, it's not just the infectious complications, but as I mentioned, the non-infectious complications are significantly important. Any questions? Thank you.